Now opioid agonist. Now you can see these are the details. Morphine, oral, IM, IV, SE, these are all routes of administration. Metabolism is through conjugation in liver and P glycoprotein. Active metabolites are renally eliminated and accumulate in renal impairment patients. M3G has no analgesic, but it is neuroexcitatory. M6G 2 to 4 times more potent, and abuse deterrent formulations are also available. Methadone available in oral, IV, and all. No active metabolite, racemic mixture. Long variables, half-life will increases risk of overdose. Very lipophilic. Duration of analgesia is much more shorter than elimination half-life. So repeated dosing will lead to accumulation. It will prolong QT interval and can cause cortisol depointers. Conversion to and from methadone and other opioids should be done with great care. Fentanyl is also available in all these parenteral routes, and no active metabolites option for patients with renal dysfunction should be used in caution. Metabolized by CYP34A, 100 times more potent than morphine and less histamine release, sedation, and constipation in comparison to morphine. Oxycodone is oral, metabolized by CYP2D6, CYP34A, and it has a warning for these drug interactions, less histamine release and nausea. Abuse deterrent formulations are available. Now oxymorphone, immediate release, has longer duration of action and elimination half-life 8 hours compared to other intermediate release opioids. Oral bioavailability will increase with food and should be administered 1 to 2 hours after eating. Bioavailability will increase with co-administration of alcohol. Now hydromorphone, these are also available in oral and parenteral, metabolized by glucuronidation, and these are eliminated and can cause CNS side effects in the patient with renal insufficiency. Abuse deterrent formulation is also available. Now hydrocodone, oral, active metabolite is hydromorphone, metabolized by CYP2D6 and CYP34A. Abuse deterrent formulations are available. Tapentadol, oral, centrally acting analgesic, mu agonist activity along with inhibition of norepinephrine reuptake. Efficacy in treating nociceptive and neuropathic pain. Metabolized predominantly by glucuronidation. No CYP450 interactions. Seizure and serotonin syndrome will occur in predisposed patients. Now tramadol, it is also given oral and topical, metabolized by phase 1 and 2, CYP2D6, CYP2B6, CYP34A are all involved. Serotonin syndrome will occur due to drug interaction, and for it is contraindicated for children below 12 years, contraindicated below children 18 years after removal of tonsils, and not recommended for 12 to 18 years old who are obese. Now warning is renal impairment, dosing is required. Review dosing recommendations for codeine. It is oral and subcutaneous. Prodrug, metabolized to CYP2D6 to the active drug morphine. Rapid metabolizers of CYP2D6 can experience toxicity. Inhibitors of CYP2D6 will prevent conversion of codeine to morphine, thereby preventing pain control. Do not use in patient with renal dysfunction. Use for mild or moderate pain. Contraindicated for children below 12 years, below 18 years if tonsils are removed, and not for breastfeeding mothers. Meperidine, oral and IV, not recommended as first line opioid choice. Active metabolites normeperidine accumulates with renal dysfunction and leading to toxicity. Naloxone does not antagonize the effects of normeperidine. Not used in elderly patients with renal dysfunction. Buprenorphine, it is buccal implant, IM, IV, long duration of action, very lipophilic, incompletely reversible. Naloxone, metabolized by CYP34A, watch for drug interactions. Strong 3YP34A inhibitor or inducers can prolong QT interval. Transdermal patch every 7 days. Abuse deterrent formulations are available.